Good evening, everyone. Welcome, welcome. I see a lot of names, familiar names here. Thank you guys for coming back. Okay, perfectly. So let's get started. You guys know I love starting right on the dot. Um, So hello, everyone. If you are completely new here, my name is Dr. Monica Gilbert, and today I have a very special guest who's going to be discussing this very important topic with me. Please, please, please mute your audio because there have been situations where, things are being said and it's like a little awkward. So just mute your audios, please. If not, I'll try to do it. I know some people forget. But anyways, welcome everyone. Welcome everyone. We do these webinars once a month and we do it on different topics. Tonight's topic is going to be on co-occurring conditions or comorbidities that we see in autism. And a lot of people were very interested in this topic. We're also going to record these, so if anyone has to leave early or, other people couldn't make it, you'll get a chance to also review this. I'm also including a link here on the chat. This link is just if you guys want to inquire about services. So I'll talk a little bit about the services that we provide, but I will be putting this link every now and then because I always get people that ask me, like, what's the number? What's this? What's that? So don't worry about it. We will contact you guys. You guys don't have to contact us. All you have to do is fill out the link. So, hello, everyone who's coming in. Again, my name is Dr. Monica Gilbert, and here I have Marianne, who is one of our registered mental health counselor interns at Crystal Mind Psychological Services. Marianne, do you want to introduce yourself?
Hi, everyone. I'm Marian. As Dr. Gilbert said, I am a licensed mental health counselor intern at Crystal Mind Psychological Services. I've also been an RBT for approximately 7 years, and currently I'm also a doctoral student.
So she is well versed in a lot of these things that we are going to be speaking about today. Please, 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 any questions that you guys have, put it in the chat. You know that I love the questions because your question can be someone else's question. So please don't feel shy and put it in the chat. All right, so let's get started. So some of the services that we provide at Crystal Minds New Beginning, which is the ABA company, and then the sister company, which is Crystal Mind Psychological Services. So we do ABA therapy, we do preteen and adult groups, and also social skill groups on weekends. We also do virtual and in-person mental health therapy sessions. And I myself, I do consultations. So I know a lot of parents are sometimes wondering, where they should go if their child has a diagnosis or if they see some of these red flags. So I can do these one-time consultations at the office. We also do psychoeducational assessments, and we have PSR vocational groups. And Marianne helps us with a lot of our psychological and psychoeducational assessments. And we also have mini assessments. So if you're trying to rule out like autism, or you're just trying to rule out ADHD for children, teens, and adults, we do those as well. And of course, parent coaching and school consultation. So again, the link that I put here on the chat, you guys can fill it out and we will contact you if you have any questions, any specific questions about our services, so that we can dedicate the time today to really speak about this very important topic. So we're going to go over the comorbidities or the co-occurring diagnoses that we sometimes see with autism, but also, and very importantly, the differentials, right? So how does autism differentiate from these other disorders? And the reason why I think this is so important is because there's so many people that come to us and are completely misdiagnosed. I don't know if you had clients, Marianne, that you have encountered that are sometimes misdiagnosed. Can you tell us a little bit about what your experience has been?
Absolutely. It happens a lot, especially with teens and young adults who might come in, for example, thinking that they have anxiety, whether it's just social anxiety or generalized anxiety. And then it turns out that some of the symptoms that they're endorsing are much more consistent with an ASD presentation, and they just don't know about it. So that's one of the most popular ones. ADHD is something that we often also see that has a comorbidity with anxiety, and performing these comprehensive psychological evaluations really does help in order to kind of address those things and rule out those diagnoses. And it can definitely help with treatment.
Absolutely. So we're going to go into each of these disorders. Of course, anything can be comorbid with autism, but we're not going to put the entire DSM book here because we just don't have the time. So these are the ones that we mostly encounter. So we'll go over this, and of course, again, you guys can put your questions here and we'll go over them. So we're going to go over social pragmatic communication disorder. We'll go over tic disorders, ADHD, OCD, anxiety disorder, which is really an umbrella, so we'll only tackle three of them: depressive disorders, borderline personality disorder, and schizophrenia. So just so you guys understand, neurodevelopmental disorders are these disorders that start from a very early age, right? It's not something that you acquire later on. It's something that kind of is born, with the individual. So in this neurodevelopmental disorder umbrella, we have ADHD, we have autism spectrum disorder, we have intellectual developmental disorder, which used to be called oh my gosh, the name is not coming up. Intellectual developmental disorder, mental retardation, specific learning disorder. And Marianne, can you tell us a little bit about specific learning disorder, since I know you work more with that since you provide the diagnosis?
So, a learning disorder can be a couple of different things. So, for example, if you were to do a psychoeducational evaluation, these evaluations typically include different tests that address the individual's cognitive, academics, social, and emotional functioning. Through them, you'll be able to identify strengths and weaknesses and learning disabilities, some as dyslexia. There's different processing disorders as well, whether it's informational, whether it's language. And those are some of the typical ones that you see and do address in psychoeducational testing.
Perfect. And then we have motor disorders. So when it comes to motor disorders, we have the stereotypic movement disorder, we have the developmental coordination disorder, and the one that we're going to speak about is the tic disorder. And then finally, the communication disorder is also part of this neurodevelopmental disorder umbrella. And here we have the social pragmatic communication disorder. Who here has heard about social pragmatic communication disorder? If you've been to our past webinars, I'm sure that you have. So just put it in the chat. I'm just curious to know who remembers what this disorder is all about. And in this communication disorder, there's also like language disorder, speech sound disorder, and childhood onset fluency. But the only one that we'll be going over is a social pragmatic communication disorder. All right, so here is a quick refresher, ASD. So in order to meet the diagnosis for autism, so Marianne, tell me, I know that you've worked with children with autism, and you've also done the ADOS testing. So Marianne actually does all of our mini ADOS assessment testings. And for those of you who don't know, ADOS is really like the gold standard for diagnosing ASD, for diagnosing autism. So what are these two components, two big components that go into this diagnosis?
So, in order to have an ASD diagnosis, you have to meet criteria for all of the following symptoms. So, there's that deficit in social emotional reciprocity, deficits in nonverbal communicative behaviors, primarily used for social interactions. And then the last one is that inability to develop, maintain, and understand relationships. So, that's the first part of it. The second part is characterized by repetitive and restrictive behaviors. Um, so those include fixated interests that get in the way of the child interacting with others, with other kiddos, of participating in any type of interaction in the environment. Then there's the hyper or hyposensitivity to sensory stimuli. There's an inflexibility and insistence on sameness. So these are the kids that typically like things to be very, very routine. And when you break them out of that routine, it can be a little bit chaotic for them and they lead to challenging behaviors. So in this criteria of the restrictive, repetitive patterns of behaviors, interests, or activities, you only need to meet two criterias. So it can be any of these four, but in the one that we showed previously, the kiddos have to present all of those symptoms in order to have that diagnosis.
And then there
And
are,
now with AS,
go ahead, go
go
ahead.
ahead.
We're just excited to talk about this part of it,
So,
but go ahead.
yes, yes. So whenever you do receive an ASD diagnosis, it's characterized by three different levels. So we have level one, which is requiring support. So a level one is the mildest, or you can call it the higher functioning autism. So individuals with level one have difficulty understanding social cues and they struggle to form and maintain personal relationships. So a child at this level may understand, they can speak in full sentences, but that back and forth social conversation is typically absent. They have some inflexibility in their behavior. They have difficulty switching tasks, staying organized, and planning. Then there's ASD level two, which is requiring substantial support. So these kiddos, they struggle a little bit more. So the social communication and repetitive behaviors, they present themselves more obviously in level two than level one. They have more challenges in that verbal and nonverbal communication, more inflexibility of behavior, more repetitive movements. They're more apparent. And they have a harder time coping with changes in their routine. An ASD level three, which is requiring very substantial support, is characterized by severe challenges in social communication and extreme inflexible behavior. So most of these kiddos tend to be nonverbal, and if they do speak a couple of words, more than anything, it's intelligible speech. They have a hard time engaging in social interaction, so most interaction is for the purpose of obtaining immediate needs. So individuals with ASD level three, as I said, it's marked by inflexible behavior, and they have a very hard time coping with changes in their routines. So at this level, restrictive and repetitive movements interfere with their ability to function.
So just to kind of summarize, because it's going to be important that you guys understand what makes up the diagnosis of autism, is that first we need this deficit in social communication and nonverbals. And then the second part of this diagnosis are the repetitive behaviors, right? So both of these things combined give us a diagnosis of autism. And this is just a quick chart of how the diagnosis has kind of like evolved. So in the older DSM, I don't know if there's some people here who remember the terms PDD, which is pervasive developmental disorder, Asperger's disorder. Some people still use that, childhood disintegration disorder, and Rett's disorder. Nowadays, we just have autism spectrum disorder. So it's that umbrella. And as Marianne was saying, it's those three levels. So social pragmatic communication disorder is a disorder that I think some people still don't understand. Some people really don't, some clinicians really don't diagnose. And basically, the social pragmatic communication disorder is the deficit in like that nonverbal communication part that we see in autism, but it doesn't have the repetitiveness that we see in autism, right? So I want to say that this is kind of like our old PDD and OS or like our Asperger's disorder. Like it would be characterized by this disorder, which is basically like deficits in using communication for social purposes, speaking differently in the classroom than in the playground, having kind of like that really hyper focus, conversation in certain things, and really like difficulties following rules, like those back and forth conversations. Like I remember working with one of my teens with autism, and she will speak the entire time. Like she will tell you about everything, and then you cannot get a word in. You're like trying to get a word in, and she's like just going on this thing, and I'm like, oh, I didn't get to say what I wanted to say about this, right? And of course, people are not going to tell them that in these social situations. They're just going to walk away. So that's when it gets in the way of them being able to build these social relationships with others. All right, so that is social pragmatic communication disorder. Any questions about that? Put it in the chat and I'll start reading it as we follow along. Marianne, anything else you want to add about social pragmatic communication disorder?
So I think one of the important things to note when we're comparing ASD versus social pragmatic is that individuals with social pragmatic disorder, it primarily affects their social communication skills. So there's that absence of the repetitive movements and the restricted behaviors. So that would be like the main difference between the two.
Perfect. All right, so let's talk about tic disorders. So I added tic disorder here because a lot of the times there are individuals, so there are kids, teens, and adults that come to us and they do have a diagnosis of autism and a diagnosis of tic disorder, right? So that can happen, right? Or sometimes they have a tic disorder and then people confuse it for autism for the repetitive behaviors in autism or vice versa. So I thought it was interesting to kind of put this here. So in tic disorder, basically, tic disorders can be involuntary movements or vocalization. So sometimes I think it gets confused a little bit because, individuals with autism tend to have these stemming kind of behaviors like hand flapping and rocking and things like that. But it's different than this involuntary kind of more like a jerk reaction that we see in tic disorder. So again, it can overlap because the repetitive behaviors and sensory seeking movements and that difficulty with that motor control. However, I have seen that in autism, they have the ability to control the movement, so it's more under their control. It's not so automatic as with tic disorder it is just something that they cannot control. Like you can add whatever reinforcer in the world and they just cannot control it. It's sort of like a knee-jerk reaction. What are your thoughts about tic disorder, Marian? I'm not sure if you've been able to diagnose this.
So interestingly enough, I have had some kiddos come in for testing to rule out tic disorder versus a diagnosis of ASD. And one of the things that parents are really focused on is those repetitive movements. But as you said, with a tic disorder, the kids really have no control over them as they're involuntary. And you see them throughout testing. There's a difference between stimming behaviors typically done because it's sensory seeking when they're excitement or it could be sensory sensitivity and they want to engage in an activity to avoid a sensory stimulation versus the tics, they just occur by anything and everything.
Yes, absolutely. And I think a good differential here as well, if you have a child that has never gotten a diagnosis and you're like, well, does he have a tic disorder? Or do they have autism? Well, first of all, take them to a professional for sure. But usually people that just have a tic disorder and not autism, their verbal or communication skills are not really compromised, right? So that would be really like the differential part to this. All right, so moving along, let's go into ADHD, attention deficit hyperactivity disorder. So in the DSM, there are three subtypes of ADHD. So we have the inattention type, hyperactivity, impulsivity, and the combined type. I've done webinars on this before. So for those of you who are coming back, I'm sure that you remember these three different types of these subdomains of ADHD. And really quickly, inattention is exactly what it sounds like. So it's an individual who has difficulty focusing, has difficulty paying attention, usually like loses things, right? Some people say, well, he's like in the clouds, he's not focused. someone with hyperactivity and impulsivity, I think this is when we think about ADHD, this is exactly what we think about, is someone who's just like hyperverbal, just speaking a lot, who's, climbing everywhere, if it's a child, of course. So that's what the hyperactivity impulsivity looks like. They're kind of blurting out answers, or the first thing that they think about, they say without really thinking about it, right? And then we have the combined type, which is the inattentive type mixed with the hyperactive and impulsive type. So those are the three types of ADHD. And you need to have 6 symptoms of each in order to meet the diagnosis for it. Because I know some people are thinking like, oh, everyone gets, ADHD, like everyone now has ADHD. Well, not really. Okay, so let's talk a little bit about the similarities with ADHD and autism, and then the differential. So how do we differentiate the symptoms of ADHD from autism? So something like really cool that you guys probably didn't know is that back in the day in the old DSM, you could not diagnose autism and ADHD. So in this newer DSM, in the DSM-5 and the DSM-5 TR, you are able to diagnose both of these together. So many individuals with ASD struggle with similar things as ADHD. So they have problems with focus, with impulse control, executive functioning, difficulties with transitions, and they tend to hyperfixate. And they also focus on tasks and are impulsive. So we see a lot of these common symptoms in individuals with ADHD and autism. I think the key here is what is the origin of these, right? So where are these coming from? Like, for example, a child or a person, an individual with ADHD, hyperactive type, when they start running around or they're fidgeting or getting out of their seat, it kind of resembles the same symptoms that we see in someone with autism that is stemming or is flapping, right? But you are able to tell if this is a repetitive behavior that they just do repetitively, or if it's something that they're trying to do because they want to kind of like provide themselves with that stimulation, right? So it kind of just looks differently clinically, but it can be a little difficult to really discern if you don't have that experience. Marianne, you want to go over the differentials?
Yeah, so I guess the biggest difference, and the point to take away from all of this is that while they do share similar symptoms, such as that sometimes impulsivity, that hyperactivity, the restrictive interest, individuals with ADHD and those who only have ADHD and not both, we don't really see those social difficulties. They may engage in sensory seeking behaviors, they may jump from one thing to another, but those social deficits are not really present.
Exactly. Perfect. Perfectly said. Questions about ADHD and autism? I know that there are a lot of kiddos, like I've seen a lot of kiddos that come to us and they have a diagnosis of autism, and then they also carry that diagnosis of ADHD. And sometimes I do agree with the diagnosis, and sometimes I'm like, no, this has nothing to do with ADHD. And I think in terms of like behavior therapy, right? Because that's what we do a lot of. It does become a little bit challenging when you have an individual that has, the diagnosis of autism and now also the diagnosis of ADHD, because you have to work a lot on the focus and on, helping them learn coping skills and helping them learn all these things. Okay, Virginia has her hand up. Yes, Virginia, you want to unmute yourself?
Yeah, I'm on pages. Um, so autism and ADHD, like what purpose does it serve to know, oh, wait a minute, this behavior is because it's ADHD or this behavior is because of this autism? Like, what is the benefit of making that?
Okay, so that's a good question. I think you were kind of coming in and out, Virginia, but I think what you're saying is that
Distinguishing, oh, wait, yeah.
okay, so what you're asking is what is the benefit of distinguishing or identifying whether this behavior is more for autism or is more for ADHD, correct? So when it comes to behavior therapy or when it comes to treatment, we're gonna do the same thing, basically, right? We're gonna get to the function of the behavior. So why is the individual engaging in this? Is it to get attention, to escape a task, whatever it is, right? So I think that it always adds insight to know like what the diagnosis is, but we have to remember that, you know, behavior is behavior. And regardless of the diagnosis, we're going to treat the symptoms or treat the behavior, right? So I think that it just gives us clinicians like more insight as to what's going on. But at the end of the day, we're going to treat it with the same behavior principles that we've used. Let me know if that answers your question. Marianne, do you want to add to that?
Thank
Um, it is a very good question, and I think that sometimes we can get caught up in the overlap, such as like the fidgeting, the stimming, the impulse control. But it's important to learn what some of the behaviors are that need to be addressed in order to, at the end of the day, provide the best course of treatment.
Yes, and I think also someone put a question here, can you have both depression and anxiety and autism? So you can, you can. We'll get to anxiety and depression, but I think that this is where Virginia's question also kind of, you know, brings a light because what tends to happen is when people say depression and you go to a psychologist or someone else, right, a clinician, they tend to directly go to medication, right? And this has, I've seen this. I've seen adults with autism that have come to me and they never knew they were diagnosed with autism, but I've been doing this for like 20 years. So when I see them, I'm like, you are in the spectrum. And they're like, oh my gosh, I've been taking medication for depression my entire life because they thought I was depressed. And after I do an assessment to rule out depression, they're not depressed, right? They're in the spectrum and they have the flat affect and everything else that goes with it. So I think that in that sense, it's important to have an accurate diagnosis because a misdiagnosis can, you know, lead you to all these other things that can also happen. All right. So obsessive compulsive disorder. So OCD. So really quickly, just so you guys know, OCD has to do with having these cognitive, obsessive thoughts. And then there's a second part to the OCD, which is the compulsive, which is a behavior that tries to alleviate these thoughts, right? So it's kind of like a mix of both of these things. So that's what gives you the diagnosis of OCD. Sometimes you don't have the compulsion, but you have the obsession. So obviously, because these behaviors are repetitive, the ones that you engage in, that's how it can sometimes get confused with ASD. So let's look at the similarities. So in terms of the similarities between OCD and ASD, we have the repetitive behaviors or rituals. We have the anxiety, we have the sensory sensitivities, and the executive function deficits. And again, it can occur together. You can have obsessive compulsive disorder and autism at the same time. Marianne, do you want to go over the differences?
Yeah, so OCD is primarily driven by obsessions that cause anxiety. When you think of OCD, think of a circle. So the thoughts produce anxiety, and in order to alleviate that anxiety, you engage in these compulsive behaviors. So that's usually what happens with OCD. With autism, it's social and communication deficits and repetitive behaviors and interests. So these behaviors, they can provide comfort or sensory regulation, but they aren't necessarily done to relieve those intrusive thoughts that are typically seen with OCD. For for OCD, there's that need for sameness tied to obsessions. With autism, there's that pervasive, and it's not really, once again, linked to anxiety. OCD individuals engage in checking. So they check things frequently because they have a fear of harm, a fear of punishment. For autism, mostly it's just done as a sensory seeking behavior or part of their routine.
And I feel like with autism, it's more of a generalized thing, right? So if a
Mhm.
child has like fixated interest or like or this ritualistic behavior, they're gonna have it with different things, right? They're gonna line up cars, they're gonna line up little things, they're gonna line up candy wrappers, whatever. So it's gonna be a little more generalized. With OCD, there's usually something more specific. And usually there's like a number to it. So they'll do like 7 or 8 or like even numbers or odd numbers. And the other side to it is that someone who has just OCD, no autism, their communication is going to be intact. So they're able to communicate, and understand social cues and all of that, which, sometimes with autism, we don't see that fluidity of conversations. So that is the main difference between both. Now, anxiety disorders. So again, anxiety disorder is this huge umbrella, and we have different types of disorders: separation anxiety disorder, selective mutism, GAD, which is what we think about when we think about anxiety, and social anxiety disorder. We also have like panic disorder. I'm not sure if I left any out. But those are, the disorder, and phobia. So those are all the disorders that go into this anxiety umbrella. So let's go over social anxiety disorder. I think this is a good one. I think this is the one that gets most confused, right? With autism, Marianne. Have you experienced the same thing?
Yeah, so with social anxiety and with autism, like with many of these comorbid diagnoses that we've talked about, there is somewhat of an overlap. So individuals may engage in gaze avoidance, so they don't want to engage in that eye contact that we typically expect in social interactions. Sometimes there's that level of discomfort in starting conversations, for example, being in parties as well. So those social situations cause a great deal of distress. They engage in social withdrawal and avoidance. So those are the typical things that we do see in both social anxiety and autism. However, the difference is that social processing. So with social anxiety, these individuals actively avoid these situations because they trigger anxiety versus ASD, they might just not like it because of hyper or hyposensitivity to sensory stimuli. So essentially, social anxiety involves intense fear of social situations due to being judged, people analyzing them, fear of acting away in a way that might be construed as negative. But we don't really see that with ASD. There's just that avoidance because they don't want to engage in certain activities.
And sometimes with ASD, well, not sometimes, a lot of the times, it's that lack of understanding social cues, right? So with someone who just has social anxiety disorder, they understand social cues, right? So the deficit is not that. With autism, right? They may not understand those social cues, so they just avoid that situation altogether. Like if I don't understand these social cues and these people are not understanding me, I'm just not going to engage, right? Again, you can have autism and at the same time have social anxiety disorder. Yes, Virginia, you want to unmute yourself?
Yeah, thank you. Especially for kids in the spectrum, right? Like I always wonder if the poor social interactions that are because of ASD would eventually lead to this anxiety, right, or this depression state. So, can you discuss a transition of ASD into these anxiety or disorders?
Yes, that's such a good question. So let's think about a child, right? Let's think about a child who's perhaps in a level 1 autism, right? So sort of like what we know as like mild autism. So this is a child who communicates well. He doesn't really understand social cues that well. Now think about this child in school, and this is a child who doesn't have therapy, right? So he's in school and then he's trying to play with others. He's trying to interact and he speaks very loud and he says things and others don't understand why he's talking about fixated interests. So they kind of just go away from this child and they don't interact. And this child because he's not receiving therapy, perhaps he doesn't learn that, okay, these are the cues or these are the things that I should learn to do or whatever it is, right? He doesn't learn those skills that he can use later on in life. So then this child becomes a teen who then is again exposed to these people and starts thinking, wow, there's something wrong with me. Maybe I'm not likable. Maybe there's something about me that others don't like. So you can see how this child can develop this social anxiety, right? So this is a child that started with ASD, and we can see how through environmental exposure, he can also develop this social anxiety disorder, if that makes sense. The key here is that cognitively you have to be able to say in therapy, right? Like, this is how I feel. I feel like others don't like me. I feel like others are avoiding me. I feel like I'm not good enough because of this, or I'm scared to be in these situations because I think others are going to talk bad about me. So in order to really like differentiate it, you have to have that verbal capacity to say those things, because if not, it's really hard. Like, how can we go into someone's right cognition to see if they're having these anxious thoughts, if that makes sense?
I have a question.
Sure.
Kids in ASD, right? Don't they normally, or shouldn't you normally recommend that aside from ABA for them to have a psychologist? Not necessarily because they have anxiety. Can you talk about that support for kids
Can you,
psychologically?
yeah, can you repeat it again, Virginia?
Yeah, so kids with ASD, I know they benefit from ABA, but knowing that there's psychological issues or right, shouldn't they also seek the benefit of a psychologist, or does the ABA help them to a certain stage, and then at a certain age, we need to be seeking a psychologist to support?
Yeah, so it depends, right? That's why I do these consultations, like even with people that, the kiddos that do ABA with us, sometimes the parents are like, well, can we do a consultation with you, Dr. Gilbert, so you can kind of tell us if we need something extra. And I do those because sometimes you do need more of that one-on-one psychological approach to help with the kiddo. At the end of the day, right? For example, when we're talking about social anxiety disorder and autism, at the end of the day, a lot of the therapy is going to be exposure therapy and teaching coping skills, right? So we're going to first teach the coping skills so they understand, like breathing techniques and things like that, and what to do in these situations when you become anxious. And then the second part to any anxiety disorder is that exposure part. We're gonna expose them little by little, which is shaping to these situations where there's other people, and then they're going to kind of like recite and use these coping techniques that they use, right? So at the end, honestly, what we're doing, what I just explained to you, is an ABA approach that is also used in mental health therapy. It's just called differently. So the treatment at the end is going to be the same, right? But the focus does have to be in those things, if it makes sense. And more so anxiety disorder. There's other disorders like depression, for example, that perhaps that warrants more of like a talk therapy and things like that. But things that are more like anxiety disorder, the treatment is based on exposure, exposing them and teaching them. Marianne, do you want to add to that? I know you've had some people that you've worked with social anxiety disorder.
Yes. So typically the treatment does involve talking about social skills and what they feel they may be lacking, things that they want to work on. So something that I do with a lot of the clients that I have for social anxiety or with ASD is figure out where they're at, how they see themselves in terms of their social interactions, in terms of their environment. Definitely engage in exposure, whether it's in vivo, whether it's in the session as well. But it is very much so an ABA approach, just with different wording. But it really all depends on the client, their level of insight into the situation, and truthfully, their age. You kind of have to take all of that into consideration while working on a treatment plan to address these concerns.
Definitely. I remember completing my doctoral studies and learning about all of these theories and all of these like interventions and treatment. And I was like, Oh my gosh, this is like ABA. You guys are just calling it differently, right? I think the main difference is that ABA therapists don't really have the training in the communication part of it, right? How to speak with clients about this and kind of like orienting them that way. But I mean they should, right? Because again, it's part of treatment. Okay, I see some more people coming in. Hello, everyone. Don't worry if you're late. We're still here. Put your questions in the chat if anyone has questions. All right, this is another one that I see diagnosed a lot instead of autism. I'm not sure if you've seen it, Marianne, but I have seen it in the kiddos that have done consultations with me where they come in with supposedly selective mutism, and then I'm asking we had one particular client a long time ago that came in. He was an adult and he came in with selective mutism, which it can happen, but you don't see selective mutism so much in adults. So he had selective mutism, or he was diagnosed with selective mutism. And then when I asked the parents, because basically selective mutism, you are selectively mute in certain situations, right? So usually it's in school or like when you meet a stranger, you just don't speak. But in other situations of your life, you're verbal, you're fine, your communication, you understand social cues, you're absolutely fine. So for this individual, they said that he had selective mutism. And when I asked the parents to show me, how he spoke at home, they had no recollection. Like they had no videos, they had nothing. And then they actually realized and they're like, wow, he's never really spoken. So long story short, we did an assessment and he was actually in the spectrum and he did not have selective mutism. So he just had difficulties with communication as a whole. Marianne, have you had, I think you've worked with a client with selective mutism.
Yes, and going off of the example that you gave, I think the biggest thing to notice is that selective mutism, they have the ability to speak fluently versus some individuals with autism, for example, those with a level 3, they may lack that ability. They may be fully nonverbal. And there are some comorbidities between the two. So typically we see that resistance to change, the repetitive thoughts, and there is that heightened stress to unfamiliar environments, which is what typically causes those individuals with selective mutism to not participate. But yeah, it goes back to really understanding and really paying attention to the symptoms for this specific individual that Dr. Gilbert was talking about. He presented the same way no matter where he was, no matter if he was with his parents or in unfamiliar situations.
And I think some people get distracted by the term selective mutism, and they think, oh, just because my child, for example, is able to talk a little bit in this situation and not in this situation, he meets this criteria. And it's not like that, right? Like there's more to it. We have to also see if there are repetitive behaviors and all the other things. So definitely, don't break your heads with this. Take them to a psychologist that knows, how to treat these symptoms, because if you also, something that I do want to say, like if you think that your child meets an anxiety disorder and also an autism disorder, right? You're not just going to take them to a clinician that has just had experience with anxiety or has just had experience with autism. It has to be a clinician that has experience with both, because that way that clinician can say, okay, it's this or that. Or they can do a thorough psychological or psychoeducation evaluation to rule one of them out or say that they both, are occurring together. Okay, so I think there was a question about anxiety disorder and depressive disorder. So we are here in depressive disorder. This is another one that gets diagnosed a lot. I see it more in like teens and adults. Like the scenario that I was telling you guys about, this adult that came to me and she was taking all this medication because they said that she was depressed and she never understood why. And she actually, what she had was autism. She was never depressed. So I see this happen a lot, depressive disorders and anxiety disorders with autism. Let me see another question here. Do you have assessments that are not intelligence assessment, but just to see if an adult has anxiety? I think that's a question for you, Marianne.
Yes, of course. There's
Mhm.
different assessments that we give in our typical testing sessions to not only assess, for example, anxiety, but it could be a different type of anxiety. It could be social anxiety. There's the importance of recognizing how long the symptoms have been present for. Um, some kiddos even struggle with academic anxiety. Something else that we typically include is personality testing, and that can help us kind of really understand what's going on. Because you may think that it's just anxiety, but it could be related to various factors in your life.
I had a parent that came in for a consultation, and so the parents like walk in, and I see the kiddo, and I'm very straightforward. Like if I see the symptoms of autism, I think it's my responsibility to say it, but I always tell them, okay, let's do an objective test just so you guys feel comfortable with it. So I'm working with the kiddo, I'm playing with him, I'm asking him questions, all that, and I see the symptoms. And I'm explaining to the parents, look, these are the things that I see, and these are the things that meet the criteria. And then all of a sudden, as we're leaving, the father's like, can I get an assessment too? Because I think that I may be in the spectrum. And I was like, sure, we do that too. So we do assessments, and you can get assessed as an adult. Even if you've never been assessed as a child, you can still do it as an adult. And some people think like, well, who cares? I'm already an adult. I've lived my life, right? Well, I think it's always good to have that insight, right? To be like, oh my gosh, like, this explains it all. I actually had a client that just started with us like 2 or 3 weeks ago that I assessed her and I told her, well, you're in the spectrum. And she started crying. Like she started crying. She was like, oh my gosh, this makes so much sense. Thank you so much. I thought my entire life that something was wrong with me, and nothing's wrong with me. I am in the spectrum. I just process information differently. And I was like, that's great.
Angelica, I see another question. Can you be 35 and just get diagnosed with autism? You can. There are individuals who are diagnosed much later in life. The one thing to keep in mind is that autism is a neurodevelopmental disorder, so symptoms have to be present during that early period of life. For example, for someone who is seeking an evaluation to rule out autism at 35, the important thing would have corroborative information. So speaking to a parent who can kind of confirm some of the symptoms that are typically seen at an early age for autism. But yeah, you can be diagnosed at any age if you feel like this is something that provides a couple of answers and kind of like, I knew it.
Yeah, some
A
insight.
little bit of relief.
I think the latest, like the oldest person's diagnosis, I don't even know how to say that, but you know what I mean. The latest diagnosis that
Mhm.
I've given was someone who was 37 years old. I don't know what was
Me
yours, Mary.
too.
You too? 37?
37.
Oh my
Yes.
gosh. Yeah. So he was 37 years old. And I provided the diagnosis. And it's always like this. I knew it was there. Everyone knew it was there, right? But we like I wanted confirmation. So it's never too late, guys. All right, let's talk about depressive disorders. Keep the questions coming, please. I love them. They're really good. Makes us think a little bit more. So, in depressive disorder, some autism specific symptoms that overlap are the flat affect. So, we see the flat affect in people who are depressed or have a depressive disorder. We also see it in autism. We hear the monotone, the social withdrawal, and the difficulty expressing emotions. Now, it's a little bit different in autism because in autism, the social withdrawal may just be to not understanding social cues, or it may just be like, I don't want to engage with you in a conversation because I like to just talk about dinosaurs or whatever it is, right? So it may just be that they choose to not engage because of those reasons, but not because they're depressed. And then the flat affect just is part of like the kind of like the mix of the emotions with the affect that we see in autism as well. So that's different than when you feel the sadness, the anhedonia, you don't want to do things you used to like to do. So there's other symptoms that contribute to the depression that we don't see in autism.
So the biggest takeaway from depressive disorders and autism disorders is that with depressive disorders, there's that persistent sadness, loss of interest, energy deficits, and individuals with autism, they typically just withdraw from situations, as Dr. Gilbert said, because they may be overstimulated or they just don't want to engage in that environment. There are comorbidities amongst the two, and it is something that we typically do see, especially with individuals who are maybe at a level 1. They do experience depression because of that social isolation, that difficulty with their daily life, and usually it's that sense that they're not understood or that they don't necessarily fit in.
Yes, perfectly said. Perfect. All right, so let's go into borderline personality disorder. So borderline personality disorder is marked by emotional instability, intense fear of abandonment. So we always see this kind of like attachment and detachment, but it's all because of this intense fear of being abandoned or being left. We see a lot of these impulsive behaviors and this unstable self-image. So again, I think that we can kind of see how a child with autism can develop borderline personality disorder, right? And I think it can start with something like the child feeling a certain way or not feeling a certain way, and then, being dismissed, like others around them, like dismissing them, and then them kind of like growing up with like this instability in emotions. Like, is this real what I feel or is it not? And just this back and forth. So we can see how borderline personality disorder can be developed, but there is a differential as well. So Marian, do you want to talk a little bit about the differentials?
Yes. So individuals with autism, they may struggle with that emotional regulation. And once again, it goes back to that difficulty with sensory, whether it's hypo or hypersensitivity, social processing differences. Um, and individuals with ASD, they do typically have that difficulty understanding emotions, that impulsivity, and that black and white thinking, which can be seen in BPD. But the most important thing to take away from this is that the differences that we see tend to be from sensory overload and social processing differences more than anything else. And this right here, we love Misdiagnosis Mondays. It presents the symptoms very well. So on the left side, we see BPD, for example, that identity instability versus autism that individuals tend to mask. And in the middle, we see some overlaps such as dissociation, diffuse sense of self. Self-esteem is impacted, especially with individuals who might be at a level 1. Autism, there's heightened emotions. We do see that on the BPD side, but they are a little bit different. Then there's that relationship inconsistency on the BPD side. Usually that's linked to this fear of abandonment, whereas in ASD, it's just an inability to build and maintain and understand those relationships. So there are a lot of things that overlap between the two, but it comes down to specific symptoms and how these situations present themselves.
Yes, and I think the takeaway is that with BPD, again, a lot of the emotionality and things like that are due to that fear of detachment, right? That fear of being left. With autism, it has to do more with auto-regulation, right? With processing of emotions and auto-regulation, things like that. We have a couple of questions. Okay, so the last one we have is schizophrenia, but let's go into these questions. What about the health of the gut microbiome heightening these behaviors? So that's a good question. I think that's for another webinar, another day, another presentation. I personally don't know a lot about it. I can tell you everything about psychology, ABA, and all that, but it's not really my area or my scope of knowledge. So I wouldn't be speaking about it too much. But I do agree that some of it can heighten certain behaviors, and the gut can contribute to some intensities in these emotions and also these behaviors. What causes BPD? Is it genetic or environmental? I think it's a combination of both. Research has shown that there is a combination of just like a lot of these disorders, right? Like there's a genetic component, there's also a chemical imbalance component, and then of course, like always, there's an environmental component as well. All right, schizophrenia. So, something that is of note is that a long time ago, when people had no idea what autism was, and in like the DSM, I don't know, two or something, don't quote me on that, but in the earlier DSMs, um, autism was actually called a child schizophrenia disorder. I don't know if you knew that, Marianne, but it was called that because of a lot of these overlapping behaviors and things like that. Later on, they did more research, they studied people a little bit more, and they realized that these were different types of disorders. So the differential diagnosis in schizophrenia is that schizophrenia involves hallucinations. So it can be auditory hallucinations, it can be visual hallucinations, and delusions and disorganized thinking, where ASD involves concrete thinking and sensory sensitivity, but does not include the psychosis part that we see in schizophrenia. Do you want to talk about the comorbidities, Marianne?
Although it's very, very rare, and I personally have never come across an individual with ASD and schizophrenia. Um, some individuals may develop schizophrenia, especially if they tend to have that social withdrawal and that cognitive decline. But it is something that doesn't typically occur.
Yeah.
And once again, the symptoms that do overlap is affect the social isolation and rigidity of thinking.
So I worked in group homes, like this was back in the day. I don't know if anyone remembers Med Waiver here. If you do, you're like as old as I am. But back in the day, we worked in these group homes, and I remember I worked with this client who was diagnosed with autism. They didn't have level one back then, but he would be like a level one autism. And I remember he used to tell me, like, I have my friend here who's in front of me. Don't you see him? He's here. And he would hang out with this invisible friend. And this was like an older, person already, like an adult. And he would hang out with his friend and he would see him there. And if you would sit on his friend, he would say, "No, you're sitting on him." So he would see the person there, right? And again, it was really hard to decipher. And I never found out if he had schizophrenia or autism, because at that point I didn't really know the differences. But that would be the only time that I can say that perhaps I was exposed to that. But I haven't seen it either. And I have worked with schizophrenia. But again, I've never seen that combination really. Some specific symptoms that tend to overlap again are the flat affect, the social isolation, and the rigid thinking patterns. Okay, and we're at the end of our presentation, but you guys can still put your questions in the chat or ask to unmute yourselves. Well, actually, we have a question here. How does schizophrenia affect memory and concentration? What do you think, Marianne? You want to take this one?
So it can affect your memory in multiple ways. It can affect your working memory, your episodic memory, especially when it comes to recalling information of certain events, because you don't, apart from the hallucinations, you have a hard time differentiating if it's something that actually happened or if it didn't. It causes you to recall information in different pieces. You make they make it harder for you to focus, for you to extend your attention for longer periods of times, just because you are experiencing all of these hallucinations.
Yeah. Imagine experiencing this auditory hallucination where you hear like five people speaking with you, right? It's going to be hard for you to focus. And if you don't focus, then you don't attend, you don't concentrate, and that has become a memory. So definitely, that's how it can get in the way of this memory and concentration. Thankfully, there are a lot of really good antipsychotics and really good medication. I think the point with schizophrenia is you have to take your medication, like absolutely have to. Because the minute you're off, that's it. The hallucinations come back. All right, so question time. What questions do you guys have? Please put it in the chat. Ask to unmute yourself. I do want you to take this home with you that if you've met one person with autism, you've only met one person with autism. I always like to bring this up when I do these diagnostic like webinars because although we are speaking about these concrete behaviors that kind of are part of this, spectrum or part of this diagnosis, everyone is different. Everyone looks different. Everyone presents different. We're all different individuals. So I think that we have to treat everyone with that respect as well. But what
Claro.
questions do you guys have for me?
Can you can you discuss how or what you think about ADHD medication and how it could trigger other mental disorders or heighten other disorders?
Yeah, so again, I'm not a psychiatrist. I'm not a psychiatrist. So I have seen individuals that when we are trying to they're diagnosed with ADHD and it's so severe, the hyperactivity or the inattention is so severe that when we're trying to teach them coping skills, when we're trying to teach them, different things, they just don't attend. They don't have the mental effort and cognitive effort to attend because of the distractions and all that. So these are individuals that I would say, we have to work together with a psychiatrist to put them on some dose of medication and work with them. I don't agree on just medicating anyone. I think that if you're going to medicate, it should be like first you should try therapy. If therapy doesn't work out, okay, then you can do the medication. However, it should be medication with therapy. And actually for ADHD, the best prognosis is when we have medication mixed with therapy. But again, understand that medication also comes with a lot of other side effects, right? So we're kind of like having the medication to help with something, and then you're going to have the other side effects as well. So that's why, and medication doesn't teach you what to do instead. It doesn't teach you coping skills, doesn't teach you replacement skills. It just kind of like eases some of these symptoms that you're experiencing. So we always have to have that other part too. We have to teach the skills of what to do in these situations. So they're not medication, dependent forever. Other questions? What other questions do you guys have? I hope I answered your question, Virginia.
You answered them all. Thank you so much. It's been great.
Awesome. And thank you for the questions, Virginia. I love them. Other questions? All right, so I'm going to leave you guys with this again in the chat. If you want to inquire about our services, you want to schedule an assessment, an appointment, you have someone that wants to, you can just fill this out and we can contact you. If not, you can always go to our website, my email, and you can contact me as well, and just ask any questions that you have. I want to thank Marianne for being here with me today. Thank you so much for doing this, Marianne. And Marian she sees clients in her private practice in Crystal Mind Psychological Services. And she also does the mini assessments and all of the other assessments that we do. You will be seeing her if you are doing an assessment for sure.
Thank you for having me, and thank you everyone for joining us today.
All right, everyone, have a great night. Get some rest, and I'll see you guys in our next webinar. Okay, remember, we do these once a month. So I'll see you guys in the next one. Bye.